Welcome everyone to the National Down Syndrome Society's webinar, Alzheimer's Disease in People with Down Syndrome, What We Know and What We Can Do About It. Thank you so much for being here. We'll give everyone just a few more seconds to join and we'll get started really soon. Thank you again for tuning in today. My name is Dana Shulo, and I am the Health Programs Coordinator at the National Down Syndrome Society, which I'll be referring to as NDSS. And perhaps even more importantly, I am also the sister to my brother, Anthony, who has Down syndrome. There are a couple of quick housekeeping items I want to go through just to ensure that everyone has a really positive experience today. We encourage you to submit your questions using the Q&A feature at the bottom of your screen. We will not be using the raise hand feature today. We will do our best to answer as many questions as possible at the end of the presentation. When you are submitting your questions, please do not include anyone's personal health information or names. We want to be respectful of privacy. We ask you to be patient with us and understand that with hundreds of registrants, we won't be able to get to every question that is asked. But we're happy to address your questions after the webinar. We invite you to email those to us at health@ndss.org. And for those of you attending live, that will be in the chat box. Please note that this webinar is being recorded. You will receive a copy of the recording in your email within 1 week, along with a list of any links and resources that are mentioned during the presentation. We will also have a copy of the slides for your review. Lastly, I want to acknowledge how difficult today's topic can be. As someone who is both a close family member as well as a health professional focusing on Down syndrome, I find myself having to turn off my sister brain sometimes and focus only on my professional brain. I also know that arming myself with the most knowledge and the greatest amount of information is the best way to prepare for all future possibilities for myself and my brother, Anthony. I invite everyone here today to keep that in mind as they're watching the webinar. And additionally, as you'll soon learn, Dr. Rafii's research is giving so much hope to our community, and I feel confident that you'll leave here feeling really thankful for his work. Founded in 1979, the National Down Syndrome Society's mission is to empower individuals with Down syndrome and their families by driving policy change, providing resources, engaging with local communities, and shifting public perceptions. NDSS supports and advocates for the Down syndrome community by focusing on 3 areas of programming: resources and support, advocacy and policy, and community engagement. As part of the resources and support programming, NDSS offers a 1-800 helpline and an info email box that anyone can reach out to with questions. We also develop resources such as this webinar that cover birth to end of life, on topics including education, employment, health and wellness, aging, and caregiving. Our health and wellness team, along with close guidance from the top medical experts in Down syndrome, work hard to create digital and printed health-related resources. We frequently collaborate with the advocacy and policy team to participate in health-related advocacy at the state and federal levels. NDSS also created the 3-2-1-GO Healthy Living program to encourage physical activity, good nutrition, and emotional wellness specifically for individuals with Down syndrome. More information about NDSS and our 3-2-1 Healthy Living program can be found on our website at ndss.org. One resource I'd like to draw your attention to is our Alzheimer's disease and Down syndrome guidebook. NDSS, in partnership with the National Task Group on Intellectual Disabilities and Dementia Practices, as well as the Alzheimer's Association, released a guidebook specifically for those caring for an individual with Down syndrome who is also diagnosed with Alzheimer's disease. This guidebook discusses a wide variety of topics, including the connection between Alzheimer's disease and Down syndrome, obtaining an accurate medical assessment, caregiving, maintaining meaningful daily activities, improving communication, and preparing for the future. You can download that for free at the link in the chat or the link on the slide. Annual Down Syndrome Advocacy Conference will be taking place in Washington, D.C. on March 20th and 21st, which coincides with World Down Syndrome Day. Individuals with Down syndrome can attend for free, and family, caregivers, and friends can purchase a discounted early bird ticket through January 12th. On Wednesday, March 20th, attendees will participate in advocacy training, learn more about legislative priorities, and hear from guest speakers. Then on Thursday, March 21st, World Down Syndrome Day, we will advocate together by meeting with members of Congress on Capitol Hill. One of NDSS's policy priorities for this event will be supporting legislation and regulatory action that includes people with Down syndrome in efforts to research, treat, and cure Alzheimer's disease. Additionally, NDSS supports action insurance coverage determinations that ensure access to and coverage of safe and effective Alzheimer's disease treatments. For more information about the Down Syndrome Advocacy Conference, please visit the link on the slide, and for those attending live, the link will also be put in the chat box. And now I am so honored to introduce our speaker for today, Dr. Michael Rafii. Dr. Rafii is a board-certified neurologist, professor of clinical neurology at the Keck School of Medicine, and the medical director at the Alzheimer's Therapeutic Research Institute. He received his MD and PhD from Brown University, has conducted neurogenetics research at Harvard Medical School, and completed his residency in neurology at the Johns Hopkins Hospital and Fellowship in Neurodegenerative Diseases at the University of California, San Diego. He's done a lot. Dr. Rafii's research focuses on developing treatments for Alzheimer's disease. He is the principal investigator and serves as the director of the NIH-funded Alzheimer's Clinical Trials Consortium Down Syndrome, ACTC-DS, an international network of over 20 sites. Thank you so much for joining us today, Dr. Rafii. Please feel free to begin your presentation as soon as you are ready.
Thank you, Dana, for that kind introduction, and thank you to the NDSS for the opportunity to speak today. Hopefully you can see my slides.
Yes, we can see. Thank you.
Thank you. So my name is Michael Rafii, and I am a professor at USC. I work at the Alzheimer's Therapeutic Research Institute, and this institute is the home base for the NIH-funded Alzheimer's Clinical Trials Consortium. We run clinical trials for the sporadic form of Alzheimer's disease, and over the past 10 years have been working on translating some of those discoveries into treatments for people with Down syndrome who seem to have a much higher risk than the general population in developing Alzheimer's disease. So my hope today is to give you an update on what we know and what's on the horizon. These are my disclosures. So this is an overview of my talk. Why are people with Down syndrome at such high risk for developing Alzheimer's disease? How does Alzheimer's disease present in people with Down syndrome? How do we diagnose Alzheimer's disease in people with Down syndrome? Is Alzheimer's disease in people with Down syndrome the same as other forms of Alzheimer's disease, namely the other genetic forms, the autosomal dominant forms, as well as the Alzheimer's disease that occurs in the general population? And finally, are there any new treatments for Alzheimer's disease in people with Down syndrome? So the first topic, why is there this increased risk for Alzheimer's disease? So on this slide, I have an image of the healthy brain on the left and an Alzheimer's brain on the right. We call it Alzheimer's disease because Dr. Alois Alzheimer's, a psychiatrist in Vienna, Austria, had a patient who had memory loss over about 5 years. And he was the first to do an autopsy of her brain And what he found in her brain, he believed explained the symptoms that he had seen. On the left, you can see that the outer part of the brain, there's a thick ribbon, a gray ribbon, that's the cortex. And as you follow it into the deeper parts of the brain, there's an area called the entorhinal cortex. And if you were to take a section of that brain under a microscope and look at it, you would see this yellow tissue. That's all the myelin that connects the axons that are connecting the neurons. And the black images, or the black spots, are actually the brain cells themselves. On the right is a brain of a patient with Alzheimer's disease. And what you can see is the brain is smaller. The cortex, that outer layer, is thinner. And when you try to follow that ribbon towards the center part of the brain, looking for the entorhinal cortex and what's called the hippocampus, which is this S-shaped area of the brain, you see that it's really not there. And when you take a piece of tissue from the brain and look at it under the microscope, you see these brown blobs, and these are the plaques of Alzheimer's disease. And Dr. Alzheimer saw these plaques, and he also saw things inside of the neurons called tangles. And of course, the combination of the plaques, the tangles, and the brain shrinkage led to the idea that these underlied the memory loss that his patient had experienced. And over time, patients have been followed and seen to have the same findings. Now, Alzheimer's disease is one type of dementia. Dementia is an umbrella term with the Latin dementis, or without thought. And in 1984, researchers took the brains of people with Down syndrome, and they took the brains of people with Alzheimer's disease, and they again looked at them under a microscope, and they specifically looked at these brown blobs or these plaques. And they discovered that the plaques are essentially identical. The protein that makes up the plaques is the same, and they named it beta amyloid. And those two researchers were Drs. Glenner and Dr. Wong. And what they expressed in their finding in the paper that they published, showing that these are the same, is that there must be something on the 21st chromosome in people with Down syndrome that results in the same plaques that we are seeing in the genetic forms of Alzheimer's disease, as well as in the late onset form of sporadic Alzheimer's disease. And that set off a race to find the gene on the 21st chromosome that may be involved in the formation of these plaques. Now, in the general population, there's been some controversy, and it's been surrounding the role of amyloid in Alzheimer's disease. Does amyloid cause Alzheimer's disease, or is it just one part of it? And this is a slide from a paper our group published a few years ago, looking at individuals in a study called the Alzheimer's Disease Neuroimaging Initiative, or ADNI. This is a longitudinal study following individuals in the general community over time, up to 10 years, conducting cognitive measures, cognitive assessments, brain imaging, including PET scans, blood tests, spinal fluid analyses. It really is the premier study of understanding the natural history of Alzheimer's disease. And in this study, this analysis, we had two groups of people identified. At time 0, their scores were all 0. Their scores were all normalized, or were the same at the outset. So these were all individuals who were normal in terms of their cognition. And they were put into two groups. One group had normal amyloid levels, or very little amyloid in the brain. And another group, the orange group, are individuals who had elevated brain amyloid levels. And these individuals were followed for 10 years. And what you'll see is that those in the blue line who had minimal elevation in amyloid over 10 years had about a 2-point decline, 1.5 point to 2-point decline on their memory score out of a 30-point test. Whereas individuals who had elevated brain amyloid after 10 years, on average, had about an 10 to 11-point loss in their memory scores on a 30-point test, so about a third worse. And this is one of many studies that has shown that amyloid certainly is a major factor in driving cognitive decline. Now, why is it that people with Down syndrome have an elevated risk of developing these amyloid plaques? So here I have 3 images of chromosome 21. And in Down syndrome, as you're aware, there's an extra copy of the 21st chromosome. And on this chromosome, there are about 350 genes. And one of these genes is called the APP gene, the amyloid precursor protein gene, so that individuals in the general population have 2 copies of the APP gene, and individuals with Down syndrome have 3 copies. And this extra copy of the APP gene is thought to be the reason why people with Down syndrome have an increased risk of developing Alzheimer's disease. Now, on this figure on the far right, you can see I have those 3 chromosomes again, and the arrows are pointing to the cell in the brain, one of the neurons in the brain. And this caricature, this big squiggly line, is the amyloid precursor protein itself. And what you'll see is that the amyloid precursor protein gets cut by these 2 scissors, these 2 enzymes. And when it gets cut, it results in the formation of a small segment called A beta or beta amyloid. This single peptide or protein, small protein, first is in monomers or single units that then bind to each other and deposit into plaques. And these are the plaques that Dr. Alzheimer saw. We know now that in the other genetic forms of Alzheimer's disease, what are so-called early onset forms of Alzheimer's disease, there are 3 types of mutations. One type is in the APP gene that results in the overproduction of the APP, a duplication. Another is a mutation in these enzymes that leads to the formation of beta amyloid. In the general population, there are no mutations. There is a normal production of beta amyloid and a normal production of this peptide that gets secreted into the brain. However, as we get older in the general population, it is thought that we are not as efficient in removing these beta amyloid peptides, and they accumulate and they result in plaques. So much so that 1/3 of all individuals over the age of 85 have some form of dementia, and the vast majority of them are due to Alzheimer's disease. So in the genetic forms, including Down syndrome, there's an overproduction of APP, and in the sporadic form, there is an under-excretion of this beta amyloid, and this results in Alzheimer's disease. There are individuals in the general population that have a mutation where their APP peptide cannot be cut by these enzymes, and that mutation is protective, and those individuals do not develop Alzheimer's disease, and they do not develop plaques or tangles. In addition, there are individuals with Down syndrome who are mosaics, who have a partial trisomy. And rarely, some of those individuals have a partial trisomy where they do not have the extra copy of APP gene. Those individuals only have 2 copies of APP. There have only been 2 cases such as this reported in the literature, and both of those individuals did not develop Alzheimer's disease pathology, no plaques or tangles, and they did not develop dementia. So it is believed that APP is the basis, this extra copy of APP is the basis for Alzheimer's disease in Down syndrome, and APP has been a focus of study for many, many years. Now, here is a graph showing the population of people with Down syndrome in the United States. And this is over the past 70 years. And what you can see is in 1950, there were only about 50,000 people with Down syndrome estimated to be in the United States. In 2013, it's well over 200,000, a quadrupling, which is terrific. People with Down syndrome are living longer, healthier, more active lives. This increase in longevity is thought to be due in part to better access to healthcare, better access to medical care. But what it's resulted in is that we're seeing more older adults with Down syndrome, particularly those over the age of 50, developing symptoms of dementia due to Alzheimer's disease. The life expectancy in 1983 was about 25 years. In 2005, it was 61. And more people with Down syndrome are living longer. And because of that increased longevity, we're seeing the emergence of more and more Alzheimer's disease. So much so that in people over the age of 35, the #1 cause of death is Alzheimer's disease. So that was why they are at such high risk. And how does Alzheimer's disease present in people with Down syndrome? So initially, I showed you that image of the brain in the general population, the area called the hippocampus atrophies away or shrinks away. And the hippocampus is known to be involved in short-term memories. And inevitably, that is why the majority of patients with Alzheimer's disease present with memory loss, short-term memory loss. And as the disease spreads, as the plaques and tangles spread through the brain, other cognitive abilities are lost. What does this look like in a person with Down syndrome? Well, memory loss is still one of the main complaints and one of the main symptoms of Alzheimer's disease in this population. But we see a whole host of other symptoms, including social withdrawal, disorientation, loss of daily living skills that have previously been acquired, changes in personality, the development of seizures, change in sleep pattern, major weight change, aggressive behavior, and the loss of speech. These are a constellation, and patients may show some or all of these symptoms over the continuum of Alzheimer's. However, there are many mimics of these symptoms: depression, anxiety, psychosis, environmental changes. These can affect some of these symptoms. Medical disorders, particularly hypothyroidism, where the thyroid hormone is not being produced in sufficient quantities, can lead to similar symptoms. Sensory problems, including cataracts and autosclerosis with individuals having difficulty seeing and hearing, can certainly affect memory function. And finally, medications. Polypharmacy, or the use of multiple medications, some of which may have effects on the nervous system, may have similar consequences in terms of symptoms and mimic cognitive impairment due to Alzheimer's disease. I want to spend one moment talking about self-talk. Self-talk is a common, developmentally appropriate, important coping tool that people with Down syndrome employ. There are commonly imaginary friends, and self-talk is not only normal, but it's actually quite useful. And people with Down syndrome use this as a way to cope with their feelings and with the way to process activities, events that occur during their days. The amount and intensity of self-talk can reflect the number and emotional intensity of those daily events. And a dramatic change in self-talk may tell us about emotionally charged events that occurred during the day, but self-talk in and of itself does not imply Alzheimer's disease dementia. And this is something that some clinicians who are not familiar with taking care of patients or individuals with Down syndrome may not be aware of. And so it's important to ensure that they are aware that self-talk is longstanding if it has been, and if there are any changes in it. And how do we go about making the diagnosis of Alzheimer's disease in dementia, in Down syndrome, sorry. So one of the main publications that came out in the Mayo Clinic Proceedings in 2013 was from the National Task Group on dementia practices in people with intellectual disabilities, including Down syndrome. And the main feature of that publication was that we need baseline assessments before the individual reaches the age where Alzheimer's dementia may be a concern. So having a baseline of their normal cognition, a baseline of their normal functioning, and a baseline assessment of their normal behaviors, so that if there is a change, we can objectively make a comparison. There are a whole host of screening tools. As I mentioned, the NTG has one also that was published. It's called the EDSD, the Early Dementia Screening and Diagnostic. And this is a great tool that can be completed. It's available in 16 languages and really just captures what is the individual's functioning at a certain time. Of course, labs can be ordered by the primary care physician, again, looking for thyroid hormone and vitamin B12 levels, which are commonly culprits in cognitive decline, a neurology consultation, brain imaging, and if an individual is showing symptoms concerning for cognitive impairment, but they are under the age of 40, then the Down syndrome regression disorder or an alternative diagnosis should be considered and worked up. The average age of dementia diagnosis in people with Down syndrome is 55 years old. And so someone under the age of 40 having cognitive changes or behavioral changes or functional changes really warrants looking for other potential causes. Recommendations have been made, including annual thyroid screening for that thyroid hormone, ophthalmological examination and hearing examination, fasting glucose levels, B12 levels, as well as a lipid profile, and again, baseline cognitive testing. And who makes this diagnosis? Primary care physicians often don't see enough people with Down syndrome in their patient panel, and they may not feel confident enough. And that's why the Global Down Syndrome Foundation and the NTG have published guidelines and tools that may be useful in a primary care setting. Psychiatrists and neurologists often don't feel confident or comfortable in doing these types of assessments, and pediatric Down syndrome clinics will usually follow individuals only up until the age of 18. And so they don't have that patient base to follow up on. Oftentimes, it's a family member or a support worker, a case manager, or a manager at a group home that notices this change over time and brings it to the attention of a loved one or a clinician. Oftentimes, it is the informant that brings this to the attention of the healthcare provider. A physical and cognitive evaluation are conducted, labs and neuroimaging are performed, and the diagnosis is made in conjunction with all of the evidence at hand. And again, the Global Down Syndrome Foundation has a website where they have a listing by state of those adult clinics that can perform these types of services. And why make this diagnosis? Well, it's for all the usual reasons that we do in the general population. Education of the person, the family, the support workers to access additional support and care, planning, including consideration of residents, and finally, access to new medications that are becoming available and expected to become available in the near future. So shifting gears now, is Alzheimer's disease in people with Down syndrome the same as other forms of Alzheimer's disease? So in 2013, we launched a study. It was a very small study of just 12 individuals. It was called the Down Syndrome Biomarker Initiative. And the idea was, can we study Alzheimer's disease biomarkers, objective tests showing us the presence of Alzheimer's disease pathology in people with Down syndrome? And so we assessed cognition. We included MRI scans, PET scans, including the latest scans available, amyloid scans, tau scans, which allow us to see neurofibrillary tangles, as well as FDG scans or glucose metabolism scans that let us look at the activity of the brain. And we also looked at fluid biomarkers, including blood tests that may tell us about what's going on in the brain. This pilot study of just 12 people was to answer the question, can such a study be done in people with Down syndrome? And what we found is that all 12 participants completed all of our procedures, all the MRIs and PET scans for the entire duration of the 3-year study. And we've published several papers showing not only were they able to participate and provide consent and successfully complete the procedures, but there were many learnings that were gained in terms of understanding how does Alzheimer's disease biomarkers look in Down syndrome as compared to the general population. The NIH then went ahead and funded the Alzheimer's Biomarker Consortium Down syndrome. This is similar to that study I mentioned earlier that's being done in the general population called ADNI, trying to just observe the natural progression from normal cognition to dementia and try to understand what tests are helpful in understanding the diagnosis, the progression, and perhaps even a way to assess treatments that may help slow down the progression of Alzheimer's disease. This study is led by Drs. Ben Handon, Liz Head, Brad Christian, and Mark Mabstone. It's enrolling over 550 participants with Down syndrome, 25 years and older. as well as 50 sibling controls across 8 sites. It measures cognition, performs MRI, PET scanning, and those fluid biomarkers such as blood tests, and the visits are done every 16 months. All of this data is being made available for researchers to use around the world, and over 100 papers have been published so far on this cohort, understanding biomarkers of Alzheimer's disease in people with Down syndrome. In fact, ABCDS is revolutionizing the way we understand Alzheimer's disease in people with Down syndrome. So what are some of the findings? So this is a slide on the left. On the x-axis shows the age of individuals with Down syndrome, and on the y-axis is what's labeled as global SUVR. That is simply the amount of amyloid that is measured on the PET scan. And what you can see is that there's a red dashed line. This is the cutoff of being positive or having elevated brain amyloid. And what you can see is that around the age of 35, most of the individuals are in blue, which means amyloid negative. However, beyond the age of 35, and particularly beyond the age of 40, you see that there are individuals in red. These are individuals whose amyloid levels are above the red dashed lines. And you can see that at subsequent scans in the following year, you can see that there's a dramatic increase or an accumulation in the amount of amyloid in the brain. So it's around 35 years that this becomes positive in terms of elevated brain amyloid. But on the right is a study that looked at the average age where dementia is diagnosed. And this paper is from the Lundowns group in the United Kingdom, led by Dr. Andre Stridham. And this has been replicated now in a number of studies showing that the average age of diagnosis is about 55 years old. And that is the age where symptoms of dementia are observed. That tells us that between the age of 35, where there's elevated brain amyloid, and 55, there's a 20-year period where we can try to intervene and reduce amyloid in the brain such that individuals do not develop dementia. This slide is data from the ABCDS study. And it has just been published, but it is a study that compared individuals with Down syndrome versus other individuals who have those autosomal dominant forms of Alzheimer's disease. And so in the x-axis is the age of the individuals. The y-axis is the amount of amyloid in the brain. Here, the units are called centiloids. The red line, the red curve, is normal controls or neurotypical individuals. And then you can see in the green, these are individuals with Down syndrome. And in the blue are those individuals who have autosomal dominant mutations that lead to an overproduction of beta amyloid. And what you can see is that, again, between the ages of 35 and 55, there's an increase in the amyloid in the brain, and the rate that it's accumulating in the brain is more profound than even the mutation carriers. Now, I've been talking about amyloid in the brain, but amyloid is just one of those 3 components of Alzheimer's disease. Amyloid is 1, tau, which makes up the neurofibrillary tangles, is 2, and then 3 is the neurodegeneration or shrinkage of the brain. Here, this is data also from ABCDS looking at tau in the brain. And the x-axis on the bottom is the amount of amyloid in the brain, and on the y-axis is the amount of tau in the brain. And the purple line is individuals who have those autosomal dominant mutations, and the orange are those individuals with Down syndrome. And you can see that on average, people with Down syndrome have more tau in their brain at a given amount of amyloid than the mutation carriers. And this pathology is telling us that from the time that amyloid deposits in the brain of somebody with Down syndrome until the time that they develop tangles is shorter than in the other forms of Alzheimer's disease. Some people believe that dementia due to Alzheimer's disease may progress faster in this population. That's still being understood, but in terms of the pathology, it does appear that the pathology of Alzheimer's disease progresses more rapidly in Down syndrome than the general population, but also in the autosomal dominant population. And you can see these are 3 areas of the brain that were looked at. where you can see the amount of tau in the brain in relation to amyloid is increasing sooner in these individuals. Finally, what is the impact of amyloid and tau and neurodegeneration on thinking and memory? So here on the x-axis is amyloid in the brain, and on the y-axis is a test called the Modified Cued Recall Test. This is a memory test that was developed to assess memory in people with intellectual disabilities. And this test, as you can see, out of 40 points, on the x-axis is amyloid in the brain. The individuals in the blue circles have very little amyloid in the brain, and they scored quite high on this test. And you can see that individuals who are in these black bow tie shapes, these are individuals who have amyloid in the brain, but also have the presence of tau. They seem to score lower. And those individuals who have amyloid in the brain, tau in the brain, and the presence of neurodegeneration, those individuals are in the X's, the red X's, they tend to also do lower on their cognitive test. This adheres to the ATN framework. This is a way to stage individuals with Alzheimer's disease. Amyloid negative or positive, tau negative or positive, and neurodegeneration negative or positive. And the ATN framework is a way to stage individuals along the Alzheimer's continuum in the general population, but now we can see that it is also applicable to people in the Down syndrome population who are developing some of the pathological changes of Alzheimer's disease. Perhaps one of the most important studies that has come out in the Down syndrome group is from one of our collaborators in Europe, Dr. Juan Fortea. And what he did is he looked at these ATN biomarkers in people who have Down syndrome, and on the right in people who have autosomal dominant Alzheimer's disease, and he plotted out all the changes over time. And on the x-axis is the estimated year of onset, so 0 being the time where the symptoms begin, the symptoms of dementia begin. And you can see before time 0, there are dramatic changes happening in several biomarkers, both in the Down syndrome population, but also in the autosomal dominant population. And this tells us that there are changes occurring in the brain before the symptoms even show up. We know this in the sporadic population, in the general population, and now we're seeing that in the genetic populations, it is the same. And by virtue of that, we can identify individuals earlier using the biomarkers before any symptoms develop, so that we could potentially prevent the symptoms from ever showing up in the first place by knowing that those changes are occurring in the brain and targeting those changes. So this slide shows you that same pathway with that APP protein that I showed earlier, the formation of those small peptides of beta amyloid, the binding of beta amyloid to itself, forming fibrils, and finally amyloid plaques. In the general population, there have now been several drugs, 2 of which have been approved by the FDA, 1 more expected to be approved later in 2024, all of which bind to beta amyloid and remove it from the brain. And what we've seen is that these drugs have different potencies. The one that is most potent is called donanemab. It binds to beta amyloid and clears the brain of amyloid within 6 months. It's a monthly infusion that removes amyloid dramatically. These medications have been tested in clinical trials in the general population, and they showed about a 36% reduction in the cognitive decline associated with having elevated brain amyloid However, these drugs that are monoclonal antibodies that target amyloid are given as infusions. They bind to amyloid and they remove it out of the brain, but there are side effects. These side effects can include changes that are seen just on MRI. They can include changes that are symptomatic, such as dizziness, headache, or they can have severe symptoms such as stroke. And so these drugs are being tested in the general population. We are conducting a trial in individuals who are completely asymptomatic in the general population, but have elevated brain amyloid. And the way that these trials are designed is to ensure the safety of the participants, such that if there are changes observed on monitoring MRIs or surveillance MRIs, these participants have their treatment stopped. The FDA has approved lecanemab and aducanumab. These are given differently than donanemab, but they are also a monthly IV infusion, and the appropriate use guidelines that have been published for these drugs all suggest or recommend that these treatments not be used in people with genetic forms of Alzheimer's disease, autosomal dominant Alzheimer's disease, and Down syndrome related Alzheimer's disease until safety studies are done to see what dose should be used, how frequently should the doses be given, how frequently should MRI monitoring for surveillance be done to ensure that these drugs are safe in this population. So finally, are there any new treatments for Alzheimer's disease in people with Down syndrome? We have run several trials targeting amyloid in people with Down syndrome. One was a compound called sialoinositol that was an oral compound. That study was very important because it showed us that we can assess cognition and behavior, but it was a very short study. It was only 4 weeks of treatment, but it was one of the first targeting amyloid in this population. Our second study was the AC Immune ACI-24 active vaccine against beta amyloid. We conducted a study, a phase 1B study of that vaccine, and we showed that there were no serious adverse events, but the vaccine was not very potent. And so that vaccine has been reformulated, targeting amyloid, and is now being tested in the ABATE trial. Again, this is one way to approach removing amyloid from the brain. The ABATE trial is enrolling people in the general population, but it's also enrolling people with Down syndrome. In 2019, we were funded by the NIH to develop a consortium in preparation for running clinical trials for Alzheimer's disease specifically designed for people with Down syndrome. We have several sites in the United States and in Europe that are all using the same protocol, using the same assessment tools, the same safety monitoring, with all of our scales translated, that sites that are expert in seeing adults with Down syndrome and assessing for Alzheimer's disease. These sites include all 8 of the ABCDS sites nationwide. Our first project was the trial-ready cohort for Down syndrome. This is a group of individuals with Down syndrome who are interested in participating in clinical trials to get access to the newer treatments, who are interested in getting involved in research. The trial-ready cohort ensures that people who come into this research are medically stable and are eligible for the clinical trials. We allow for co-enrollment in that ABCDS longitudinal study, but also work with the NIH DS Connect registry and can have direct recruitment into this study. Initially, we were going to enroll 120 participants. We are now at 190 participants and are aiming to enroll 250 participants in the trial-ready cohort. And the idea is that an individual in the trial-ready cohort will be offered several clinical trials that they may be eligible for. And if they are interested, they can participate in some of these trials. The first trial is called the ABATE trial, and I mentioned that earlier. This is a study looking for individuals with Down syndrome between the ages of 35 and 50. The study is specifically designed for people with Down syndrome and is testing a vaccine that targets beta amyloid. We want to know that the vaccine is safe. We want to know how the vaccine works in the body, what the immune response is, if it helps remove amyloid from the brain, and if it slows down memory and thinking problems in the brain. So in summary, people with Down syndrome develop a genetic form of Alzheimer's disease, and treatments are urgently needed for this population. What we've seen from the ABCDS study is that Down syndrome-related Alzheimer's disease is nearly identical to autosomal dominant or other genetic forms of Alzheimer's disease, where there's an overproduction of beta amyloid. There are now FDA-approved treatments for early Alzheimer's disease, individuals who are not too far along in the dementia path, but do have signs of mild cognitive impairment or mild dementia, and these individuals are getting access to these new monoclonal antibodies. There are now blood tests available that tell us about elevated brain amyloid and will soon be covered by CMS and insurance. We have now used these blood biomarkers in all of our trials to pre-screen individuals just with the blood test to see, do they have elevated brain amyloid? And if they do, based on the blood test, then go forward and do a PET scan. This is analogous to somebody having elevated cholesterol on the blood test and then going forward and getting an angiogram looking at their coronary arteries for atherosclerotic plaques. There are additional clinical trials that are being planned for 2024, and we have the ACTCDS website listed here. You can come back and look at updates that we'll be posting about opportunities to participate in research. These are our collaborators. It takes a large number of people to develop, design, conduct, and report clinical trials. And the NIH has been supportive through the Include initiative to incorporate the Down syndrome population into all of the advances that are being made in Alzheimer's disease therapeutics. I'll stop there and thank you for your attention.
Thank you so much for that presentation, Dr. Rafii. We now have about 13 minutes for questions. Please feel free to use the Q&A feature that's at the bottom of your Zoom screen. I know we've had a few people already send their questions in, which is great. Just a reminder, due to the number of people who are attending today, we will not get to every question. If your question is not answered, please feel free to email help@ndss.org, and we will do our best to get additional information to you. So Dr. Rafii, there are quite a few people asking, are there any lifestyle, health choices, exercise, weight management, supplements that could potentially delay or postpone the onset of dementia?
Yes, that's a good question. Anytime you see anything published in a magazine or advertised, ask yourself the question, was it tested in a randomized, double-blind, placebo-controlled study, particularly for supplements? If there is not a gold standard of assessing for safety and efficacy, I'm not sure that it warrants taking that supplement. So you really want to see objective evidence, and a randomized, double-blind, placebo-controlled study is that gold standard. As far as we know, lifestyle changes such as diet and exercise are good for the general brain health in the general population. There is an exercise study that was just conducted designed for people with Down syndrome at the University of Kansas. We're hoping to see the results of that. But as far as we know, what's good for the heart is good for the brain. And so aerobic exercise in moderation in someone who is able to participate is terrific, and you will derive metabolic benefits from that. But whether it directly impacts cognitive decline related to Alzheimer's disease, that question has not yet been answered.
And would you mind touching again on if there has been research done regarding the use of Alzheimer's disease treatment medications and how individuals with Down syndrome might respond differently to those than individuals in the general population?
Yes, that's a great question. So these monoclonal antibodies are essentially harnessing the power of the immune system to remove what we think is the toxic element in Alzheimer's disease. And monoclonal antibodies, or so-called immunotherapy, is used for cancer, rheumatological conditions, autoimmune conditions. And IVIG, which is another type of immunotherapy, is used in people with Down syndrome. And we have published results with IVIG, and the responses are similar as in other populations. The only important caveat to keep in mind with the use of amyloid-lowering antibodies in the genetic forms of Alzheimer's disease, including people with Down syndrome, is that they have an elevated amount of brain amyloid from a very young age. And that means that they are we believe, at a higher risk for developing some of these side effects. That doesn't mean that these treatments can't and shouldn't be used. They just have to be adapted for use in this population, whether it's a dose or dosing change or the interval by which that the medication is given, how frequently it's being given, and whether a titration needs to be used to give these treatments safely. And those are questions that are typically answered as part of clinical trials.
Yeah. Do you often see the development of seizures in individuals who are developing dementia?
That's a great question. And I touched on seizures as heralding dementia in a person with Down syndrome. There's actually a bimodal distribution of seizures in Down syndrome. There is a peak that occurs in infancy and early childhood. That is one type of seizures that's seen. And then the second epoch of seizures occurs in late life, typically in their 50s and 60s. And it seems to correlate with the onset of dementia. And this has been published by several investigators, including Dr. Ira Lott, who's been studying Alzheimer's in people with Down syndrome for many years. And it does seem to correlate with the onset of dementia.
Thank you. Could you discuss again what the advantage of the vaccine-based amyloid removal drugs are or would be over the antibody-based drugs?
That's a great question. So these monoclonal antibodies are based on the idea that we can harness the power of the immune system to clear out this toxic element, beta amyloid. Not all antibodies are the same. They target different species of amyloid. Some of them bind to the monomers, some of them bind to oligomers or groups of them, some of them bind to the actual plaque form of beta amyloid. And there are different behaviors of each of those, but they require a once a month or sometimes once every 2 weeks infusion. And with infusions, there can be infusion site reactions. There can be reactions to being given this medication. And as I mentioned earlier, this ARIA, amyloid-related imaging abnormalities that are only seen on MRI, but can be symptomatic. The vaccine, on the other hand, is where the person's own immune system is being activated to go after amyloid in the brain. And vaccine studies have been studied in the general population, have been conducted in the general population. And what the benefit of a vaccine study is that it elicits an immune response from the patient's own body, from the individual's own body, and does not require a once a month infusion. It could be a once every 6 months injection. And so there are differences there. But at the same time, the vaccine can have a reaction at the vaccination site. It could be perceived as a treatment that is you're not able to stop immediately as you are with an infusion. So there are differences in each of them, but both of them are trying to harness the immune system and have been tested widely in the general population, and I think are now slowly coming into the Downs population as well.
Yeah. We have a family that wrote in and said that their daughter has been determined to be postmenopausal, and they're wondering if she might be at higher risk for Alzheimer's disease because of that.
So menopause is thought to have cognitive symptoms associated with it in the general population. And this reflects really hormonal effects on brain functioning, not necessarily Alzheimer's disease. Hormone replacement can be one way to tackle those menopause-related cognitive changes, but it has not been shown that those hormonal replacement therapies have an impact on the coexisting risk for Alzheimer's disease. And there have been studies published looking at estrogen replacement for the treatment of AD-related cognitive decline, and those have not been positive. But certainly the treatment of menopause-related cognitive symptoms do, in the vast majority, do seem to respond to hormone replacement therapy.
We also have a few people writing in that are looking for a clear definition of Down syndrome regression disorder and how it is alike or different from Alzheimer's dementia.
Yeah, thank you for that. So I think the last NDSS webinar, or a recent one, was on that topic by one of our colleagues, Dr. John Santoro. But the Down syndrome regression disorder is a condition that is thought to be autoimmune in nature and is thought to occur in much younger ages than Alzheimer's disease dementia. So both of them, Down syndrome regression disorder and Alzheimer's disease and Down syndrome, both of them result in the loss of functional abilities. So abilities that have been learned that are now lost. In dementia, there's a slow progressive decline. In Down syndrome regression disorder, this is in a much younger population. Instead of 55-year-old, it's 25-year-old. And it can be quite acute. It can happen over a fairly short period of time. It is not a slowly progressive condition. And so it can be acute, and it can be quite severe, leading to other symptoms such as catatonia, mutism, and very severe neurological symptoms. So although both of them result in the loss of functioning, they are very different in terms of the age of onset. And what Dr. Santoro and colleagues have been looking at is to treat the autoimmune activity that's happening in people with Down syndrome to see if we can improve their symptoms. And there have been several papers published and a clinical trial now in progress looking at some ways of targeting the immune system to improve symptoms related to Down syndrome regression disorder.
Thank you. And you're right. The Down syndrome regression disorder webinar with Dr. John Santoro can be found on our website on the Down syndrome regression disorder webpage. I will include a link to that in the follow-up email. We also have several people asking if a family history of Alzheimer's disease increases the risk for their child with Down syndrome.
So I just want to be clear that in the general population, having a family member, a parent or a grandparent who had confirmed Alzheimer's disease, that does seem to increase the risk for that individual to develop Alzheimer's disease in the general population. In the Down syndrome population, a person with Down syndrome who has trisomy 21 with that extra copy of APP, they're going to be at a very high risk for developing Alzheimer's disease, regardless of whether a parent or a grandparent had the sporadic form of Alzheimer's disease. The Alzheimer's disease that occurs in people with Down syndrome is driven by the genetics of having that extra copy of APP.
Thank you. And would you mind giving the website that was on one of your last slides? And we'll put it in the chat. We had a few people ask for it.
Definitely. I will put it on here right now into the chat for you.
Oh, thank you so much. We'll also include that in the follow-up email. And finally, what would you say to a family or an individual who is thinking about participating in Alzheimer's disease research, but is a little apprehensive or nervous about the safety?
Yeah. So you've got to talk to the site, talk to the clinician at the site, get as much information. These studies all are overseen by the FDA. All of them have an IRB, an institutional review board, that looks at the consent, makes sure that the consent is clear and gives the risks that are associated with participation. The decision at the end of the day is the participants and the families in terms of whether they're willing to spend the time and the energy and the effort, not just the risk associated, to be involved in the study. Most of the studies being conducted are placebo-controlled, meaning that there is a group of patients or individuals in the study who do not get the investigational treatment. And there are a number of studies that include an open label design, meaning that even though some proportion of people will get placebo, at the end of the study, everyone will be offered the treatment for an extended period of time. That's called an open label design, so that some people don't want to be in a study if they're only going to get placebo. The open label design often helps overcome that.
Thank you so much. We're out of time, but I want to thank you, Dr. Rafii, for not only your presentation today, but all of your work in this really important area. It was an honor to have you share all of your knowledge with us today. To everyone listening, remember that the recording of this webinar, as well as a PDF version of the slides, will be emailed out to you within 1 week. Any additional questions that you have, I know I'm sorry we didn't get to all of them, but they can be emailed to us at help@ndss.org, and we'll do our best to get you information. If you have time, we ask that you fill out the survey that will appear when the webinar is over, as it helps us plan future webinars and serve our community to the best of our ability. Thank you so much for attending today, and we'll see you on the next webinar.